tissue repair and regeneration. And so typically what happens is that the same stimuli that induces death and inflammation is the same thing that also triggers repair and regeneration. And the inflammatory cells that are recruited to clean up the necrotic debris after inflammation occurs are the same mediators that control the synthesis of new material. And whenever you have an injury, the repair process involves two main things. There's regeneration by the parenchymal cell of the same. So if you have the and if you have
Labile, please, can you mute your microphone? You're giving us a lot of feedback.
So then there's also replacement of the connective tissue parts.
Madam, please, we did not hear the previous like because there was so much noise coming from the background.
Okay. So the repair, regeneration, and then replacement, okay, of the connective tissue by fibrosis. Okay. So when we talk about regeneration, there are several things that are involved. First of all, there's cell migration. So when a wound has been created or inflammation has occurred, it means that there has been destruction of the cells in that region. So first of all, the cells will migrate to that particular area of the injury. Then there will be proliferation of the cells that have migrated so that they can populate the place. Then when they proliferate, they differentiate. So if you have connective tissue cells, they will differentiate into the particular type of connective tissue cells that are in that particular region. Then you have the synthesis of the connective tissue matrix. So the connective tissue matrix is like the cement or the glue that binds the connective tissue together. And all these processes requires an intact basement membrane. If the basement membrane is absent, then regeneration cannot occur. Then the tissues will heal by scarring, and then you see that a scar has been formed at the site of injury. So okay, so the number of cells in a particular cell population is determined by the cells that die and then the ones that are replaced by proliferation. And so if you have a cell population, for example, this one, the stable baseline population is always changing because some cells will die by apoptosis and then some too will differentiate. And then also some of these cells would proliferate. So the cell is always in constant dynamics, or the tissue is always in constant dynamics. Now, the cell proliferation is stimulated by growth factors. It's also stimulated by injury. Like I said earlier, the things that lead to injury and cell death are the very things that stimulate cell proliferation. Then it's also stimulated by mechanical deformation of the tissue. So whenever the tissues undergo some change or some damage, that also stimulates cell proliferation. And the very things that will stimulate the proliferation will inhibit cell growth. Okay. So sometimes when you have an excess of the stimulators, and so you have the things that stimulate cell growth are in excess, and you have a deficiency of the things that inhibit cell growth, then in all you have a total cell growth. Okay, because the things that will cause the cell growth to be stimulated are more than the ones that will inhibit the cell growth. So in totality, there'll be growth. Now, the cell cycle is the cycle through which the cells undergo when they are going through their growth process. And the first stage is the pre-synthetic growth phase. We all know about mitosis, meiosis, cell division. So before the cell grows and divides, there has to be a pre-synthetic growth phase whereby the organelles would be replicated. So if you have mitochondria, you replicate the mitochondria to prepare for the cell division. Then after that, there also has to be the DNA synthetic phase, or the S phase, where the DNA will be synthesized. Then we have the pre-mitotic growth phase, which is like a resting phase. After that, then the mitotic phase will come in, where the cells will actually divide. Now, because the organelles have been divided, or the organelles have been synthesized already, when the cell divides, you have equal numbers of the various organelles in the daughter cells. And the cells which are not undergoing any of these changes are in a quiescent physiologic state called the G0. So this is just a diagram of the cell cycle. So from the G1 phase, you go to the synthetic phase, which is a DNA synthetic phase. Then G2 is like a resting phase before we go to the mitotic phase. Now, before a cell goes through the cell cycle, it has to be activated by a family of proteins called cyclins. And these are the ones that will help the cell to complex through the cell cycle. Now, the cyclins also are regulated by a set of proteins called cyclin-dependent kinases. You have all these regulations inbuilt so that the system doesn't go haywire and then the cell continues dividing uncontrollably. So at every point, there are always checks and balances. Okay, so the growth factors that will induce the cell growth are controlled by genes, and these genes are called proto-oncogenes. These are the genes which cause growth, or they cause cell division. Sometimes when you have mutations in these proto-oncogenes, it can lead to cancer formation. Actually, cancer is just uncontrolled cell growth and cell division. So, like I said, when these things go haywire, it can lead to uncontrolled cell division. So, looking at the division of the cells, so what we are doing is trying to sort of lay the foundation for what we are about to discuss, which is the cell growth and then the tissue repair. Before we get to tissue repair, we have to understand how the cells grow and how cells proliferate. So see this as a sort of background before we build on the foundation. So if you want to look at the ability of cells to proliferate, there are three different kinds of cells based on this ability. We have labile cells, we have stable cells, and then we have permanent cells. So labile cells are the cells that are continuously dividing and dying and regenerating. So examples are the cells of the bone marrow. They are constantly undergoing cell division, or cells of the oral cavity, the mouth, or cells of the skin, okay, cells of the vagina, cells of the cervix. So they are constantly undergoing cell division, okay. Now, other examples are cells in the urinary tract and the GI, salivary glands, and so on. Okay, so we move to stable cells. So stable cells are cells which they are stable. They have a very low level of replicative capacity, and they are capable of undergoing rapid cell division when there's something. So this is like the parenchyma of most solid organs. So for example, the liver. The liver doesn't ordinarily divide, but when there's an injury to the liver, you'd realize that the liver will start dividing. We looked at compensatory hypertrophy some time back, and we said that this can occur in the liver when maybe there's resection of parts of the liver. Within a few hours, you see that the liver cells would proliferate and go back to the original size. So the liver is an example of a stable cell. Then permanent cells. So permanent cells are terminally differentiated. They don't have any proliferative potential. Examples are the neurons of the brain, cardiac cells, skeletal muscles. So this means that if you have an injury to the brain or the heart, this injury is irreversible because the tissue cannot proliferate to cause regeneration. So what will happen is that the injured tissue will be replaced by scar tissue. Okay. Another background that I want us to understand is extracellular signaling. Before we said that the signals that cause the cells to proliferate, the signals that cause inflammation are the same signals that will cause the cells to proliferate. And so let's try and understand what these signals are. So cells send signals amongst themselves. So the signals are sent by either autocrine signaling, paracrine signaling, and synaptic signaling and endocrine signaling. So I'll proceed to explain each of these. So when we talk about autocrine signaling, it comes from the word auto. Auto is like self. And so what it means is that the cell secretes a soluble mediator that regulates itself. So sorry. Sorry, I'll be done soon. Okay, so that's what autocrine is. So example is cytokines. Or when we take the liver, the cells that undergo regeneration, the resected cells which are left, they send a signal to themselves for proliferation and growth to occur. Okay. So this is an example of an autocrine signaling. You see that a cell produces chemicals which are the little red dots. Now these chemicals have a site on the same cell and cause changes in the cell. Okay. Then we have paracrine signaling. So paracrine signaling is when the cell produces signals which acts on adjacent cells. So for example, we just talked about inflammation. When you have the chemotaxis ongoing, that is a way of attracting the white blood cell to the bacteria. So the signals are produced by one cell and act on another cell which is adjacent to the target. Okay. Then we have synaptic signaling. That's like if you take the nerve endings or the neurons. So the neurons will produce a neurotransmitter. The neurotransmitter will cross a synapse and then act on a muscle cell, which is distant from the neurotransmitter. Then the last signaling is endocrine signaling. In this case, the substance that is secreted is very far away from the target cell. So for example, the brain produces anterior pituitary hormones. Let's say growth hormone. Growth hormone is produced, but the growth hormone acts on at the ends of the long bones to cause elongation or increase in height. So you realize that the site of production of the hormone is very far away from the site of action of the hormone. And so this effect is mediated by carriage in the bloodstream. So the bloodstream will carry the hormone to the target of action. Okay. So now we are going to talk about the process of wound healing properly. We are going to look at fibrosis. So fibrosis is when the damage to the tissue is repaired. And under these conditions, the repair is by replacement of a parenchymal tissue. Okay, so there are four main components of this repair process. Firstly, there's formation of new blood vessels. Then you have fibroblasts migrating to the site of repair. When they get there, they will proliferate and then they will deposit extracellular matrix. And then the extracellular matrix will mature and then there'll be reorganization of the fibrous tissue. It's just like you have, so the new blood vessels, they are like, it's like maybe you're putting up a building. Before you start the building, you need to get your raw materials there. So, and then you get your workers there. Then the work will start. You can't do anything without the raw materials, without the workers. And so this is the same thing. For fibrosis, you need the new blood vessels to form because the new blood vessels are the ones that will supply the nutrients to the site of the injury. Then the fibroblasts are the cells that will proliferate and produce the extracellular matrix, which is the connective tissue glue. Then once it is produced, these will all be reorganized to form the tissue. And usually the wound repair begins within 24 hours of injury. So as soon as the injury occurs, there's migration of fibroblasts to the site. Then by 3 to 5 days, you have a specialized type of tissue called granulation tissue. So if you have a wound, if you've ever had a wound, I'm sure most of us have had wounds, you realize that initially there's bleeding at the site, and then after about 24 hours, you see that there's a thin line that forms across. So sort of trying to seal the edges of the wound. If you were to poke or take off that seal, you'd realize that there's a pinkish tissue underneath it, and that is what we call granulation tissue. It is very soft, it is friable. If you scratch it, it will bleed again because there are new blood vessels which have been formed, which are very fragile. And so if you disturb that, you have bleeding. So this granulation tissue will gradually accumulate the connective tissue matrix, which will strengthen it further. Then scar tissue will form on the granulation tissue, and this will strengthen the wound further. As the healing process progresses, the number of new blood vessels would gradually decrease because now the wound is stronger and doesn't need all those nutrients being brought to it anymore. So with time, the new blood vessels that have been sent to that area will decrease. Then you have collagen deposition to strengthen the wound further. So usually, the collagen synthesis begins by day 3 to 5 of the wound occurring. And many of the growth factors that lead to the collagen synthesis are the same ones that would help with the stimulation of the extracellular matrix. Oh my goodness. Okay, so usually it is the dense collagen that strengthens the scar tissue. Okay, this is the same remodeling. Okay, so these are a few growth factors that help with the growth and strengthening of the wound. So we have epidermal growth factor, transforming growth factor, fibroblast growth factor, platelet-derived growth factor. So these growth factors, some of them are stimulated by the cells which are involved in the injury themselves. Some too are produced by adjacent cells in the vicinity of the wound, and they act on the fibroblast either by autocrine or Paracrine Signalling. Okay, so the wound healing itself is a very complex situation. Usually it is also affected by physical forces. So let me, as an example, if you have a wound and you keep scratching the surface of the wound, it doesn't heal because there's formation of new blood vessels, you have friable granulation tissue, you have scar tissue being formed. Hey, how come today the meeting is, or maybe the slides are a lot? Can we extend it?
No, unless it ends and then we'll restart another 40 minutes.
Oh dear. Okay. Okay, let me see what I can do. So the steps. First of all, there's an acute inflammatory response. Then there's cell regeneration by migration and proliferation of the cells to the area. When they get there, the fibroblasts usually, they synthesize extracellular matrix. And then there's remodeling of the parenchymal elements. And then you have deposition of collagen to achieve wound strength. So usually this is what happens. So in the sequence of events, you realize that inflammation always comes first. Then there's formation of granulation tissue and there's collagen accumulation and wound contraction. You realize that there's an overlap of all these processes. So whilst inflammation is ongoing, granulation tissue formation has started. By the time inflammation ends, the granulation tissue is well formed. Then you have collagen accumulation and wound contraction. So they overlap each other. It is not discrete processes that occur. So there are two types of wound healing. There's healing by first intention and healing by secondary intention. So healing by first intention is the kind of healing that occurs in a surgical wound. And usually the edges of the surgical wound have been opposed by the suturing. And so the edges are very close to each other and it helps with the healing. The healing goes on very smoothly. So usually what happens is that there's a very narrow incisional space, which is filled by fibrin clotted blood. So this is basically what we are talking about. You have a small incisional wound here. And within 24 hours, you see that neutrophils will migrate to the incisional margin, and then they migrate towards the fibrin clot. Then the cells at the base of the epidermis will start proliferation by mitotic activity. So there'll be increased mitosis. So these cells would regenerate very quickly. Now, by 24 to 48 hours, what happens is that the epithelial cells from both edges will migrate towards each other and proliferate along the wound edge. And these would deposit extracellular matrix in the midline. So that is what will form the scab. Okay. So after this, by about the third day, you see that the wound starts filling in from the bottom to the top. But at the top, there's usually this cap which has been formed from the clotted blood. So it sort of seals the surface of the wound. But underneath, the healing starts from the bottom and progresses up. So you see that granulation tissue gradually fills up the site of the incision. Now, after that, then the collagen fibers will become deposited and then they'll eventually breach the wound. By day 5, the new blood vessel would have reached this peak and then they'll start decreasing. and the whole wound would have been filled by the collagen debris. From here, what happens is that there is strengthening of the wound by continuous deposition of collagen. And usually you realize that by the second week, the stitches are removed. So for a surgical wound that is made with non-absorbable suture, the stitches are removed from the second week. So they usually say that come on day 7 for the stitches to be removed. Usually by this time, the granulation tissue has been formed, collagen has been deposited. However, the wound is not strong, and so it's still fragile. And so when you remove the stitches, you'll be advised not to stress or exert yourself, because any physical force or stress on the wound will cause the wound to give. And so usually a few weeks after the wound, the whole place is healed up like this. So by the end of the first month, usually you see that the scar consists of cellular connective tissue and then a normal epidermis. But however, the tensile strength of the wound increases. Is the ability of the wound to sort of be able to cope with stress that is placed on the tissue. Okay. We look at healing by secondary intention. So basically what this means is that you have a wound which has a big wound. The wound is big, such that there's a big gap or a big hole created in the tissue. And usually this occurs in areas of infarction. No, I don't think we've done infarction. Okay. But infarction means an area of dead tissue as a result of blockage of blood supply. And so this would create a big defect in the tissue, and it will be filled by secondary intention. Or if you have an inflammatory ulceration, same thing. Or you have an abscess formation, maybe you have a boil, and then the pus has come out. So once the pus comes out, you have an open wound. The open wound is not small like a surgical wound, it's quite a big wound. Or if you have a large wound. So all these are wounds that will heal by secondary intention. As a rule, in surgery, you don't suture wounds with extensive tissue loss, which is complicated by infection. So for example, if you have an abscess which ruptures, you don't go and suture the hole that is left. You leave it to heal by secondary intention, because there's a lot of infection. It's an infected wound, so you don't suture such a wound. If you suture it, you'd rather make the infection worse. So you leave it open, you let the pus drain, and then you can do the suturing. Sorry, you don't do the suturing, then it heals by itself. So this is what I mean. You have a big defect in the tissue, and it is healed by secondary intention, such that the edges would come together. Now, in these situations, usually there's regeneration of the parenchymal cells, but because there's a large wound, there has to be an extensive ingrowth of the granulation tissue. You need more granulation tissue, so such a wound will take a longer time to heal. And usually it is also followed by accumulation of extracellular matrix and scarring. Okay. So this takes a longer time than the healing by primary intention. So let's look at a few differences between healing by primary intention and healing by secondary intention. Usually the secondary healing occurs in severe and big wounds. And usually For the healing by secondary intention, the large tissue effects have a greater volume of debris and exudates and fibrin, which must be removed by inflammatory cells. And so for them, they have a more extensive inflammation and healing going on comparing to the healing by primary intention.